Okay, we want to spend this PowerPoint video talking about the female reproductive system, which is exceptionally more complicated than the male reproductive system, which we'll talk about in a subsequent video. But let's talk about the female reproductive system to start out with. First of all, we talked a little about this in our initial discussion. The female reproductive organ is basically the ovary, and what inside the ovary are multiple small little areas called follicles, and inside these follicles, which are little containers, are ovum, or the egg, as you might think of it as. And what happens is there are a certain limited number of ova in the ovum. You don't keep, females don't continue to make those every month and things like that. However, what happens is under the stimulus, like I talked about earlier in the previous video, under a stimulus from a hormone coming from the pituitary called the follicle stimulating hormone, a certain very exceptionally limited number of these follicles and ovum will start to develop, mature, ripen, and enlarge. Okay, so the ovary becomes the place for these ovum, which are there, are residing there, to be able to mature and develop and to grow, and eventually the ones that are stimulated to mature and develop or grow up or ripen, eventually what will happen is they will extrude themselves to the wall of the ovary at a period of time called ovulation. Okay, so that's what the ovary does. It really contains the ovum as well as a place for the selected ovum each month to be able to mature and develop and grow. Okay, we also know that the ovary is really responsible because it does provide the basis and formation of a number of different hormones, such as estrogen, which is a largely female hormone, and progesterone, which is also in females. Think about this. Interesting about estrogen is estrogen and testosterone are really close chemically, and estrogen can be converted to testosterone. Testosterone can be converted to estrogen, back and forth. Okay, we'll talk a little bit more about that later on, but that's important. What the estrogen does in the female reproductive system is at the beginning of each menstrual cycle, at the beginning each month. Okay, what will happen is the estrogen levels will increase as well as the FSH levels. They increase, and what that does, that increases the thickness of the inside lining of the uterus, which is called the endometrium. We'll talk about that a little bit later. And so as a result, the inside lining becomes a little bit more appropriate or acceptable for implantation of an ovum, should that ovum become fertilized, like we talked in our previous PowerPoint discussion. Okay, and then also what happens is once the ovum is expelled from the side of the wall of the ovary, okay, in the middle of the cycle, around the 14th day, somewhere in that, give or take a day or two, what happens is the area that the ovum was expelled from fills with this yellow material called a corpus luteum, or the influence of another hormone from the pituitary called the luteinizing hormone, or LH. And this corpus luteum then also helps to spurn the secretion of or stimulate the secretion of another hormone called progesterone. And what progesterone does is it makes the inside lining, the endometrium, better. So the estrogen makes the endometrial wall thicker, and the progesterone makes it better. We also know that estrogen, as the female hormone from the ovary, also is very important in the development of secondary sex characteristics, such as development of body hair, breast development, and stuff like that. And we also know that estrogen, by the way, is also exceptionally helpful and important in the deposition of calcium in the bone in females. After menopause, when the estrogen levels just drop off the face of the earth and they diminish significantly, what we find is females are much more likely postmenopausally to develop osteoporosis, and that calcium doesn't get deposited in the bone nearly as well. So we'll talk a little bit about that as the time goes on, and talk about those things individually. This is just a picture of what an ovum might look like. I don't know. I've never seen one that close anyway. And again, the ova are basically present from birth in females in the ovaries. Okay, and again, a select few each month are chosen to mature and develop, and then they're released from the ovary. They spit through, like I say, as they get larger and develop, they actually migrate closer to the wall of the ovary, and in that mid-cycle period of time, they actually spurt out of the wall of the ovary, and they're swept up in the end of what's called the fallopian tube. They're little fingers at the end of the fallopian tube, which are called fimbria, and these fimbria sort of wave the ovum down the fallopian tube, and the ovum goes down the fallopian tube, where it may or may not be fertilized by any spermatozoa. Okay, Again, this happens in a 21 to 28, sometimes 30-day cycle, depends upon the female, which is quite variable, up until the point of menopause. And at the point of menopause, what happens is at that point, the ovum have pretty much almost run out, and you can't call out for another shipment because they're just not made. So the ovum have pretty much run out, and therefore menopause becomes a period of a cessation of that fertile period of time, as well as reduced hormone production. They don't need the estrogen to increase the thickness of the wall of the endometrium anymore. Okay, so and sometimes that decrease in the estrogen, the falling of the estrogen that we see with menopause results in other things like females will complain of hot flashes. There's vaginal drying, vaginal atrophy, a number of other factors that may occur during that menopausal and postmenopausal period. Okay, well, let's talk about the female reproductive organs to start out with. First of all, let's talk about the external genitalia. In the external genitalia, the first thing we start out with is the vulvar region. And the vulvar region would be the area on both sides of the area, the opening of the vagina. That'd be the vulvar region. Okay, there are a couple parts that, first of all, the labia majora, and the labia majora are large skin mounds that are on both sides of the vaginal opening. And within that, inside that, are the labia minora, which are smaller, more mucous membrane lips that would be on the inside, which if we're looking at this would be this area right in here would be the labia minora. Okay, so that's what we see, the difference between the two: majora on the outside, the minora on the inside. The vaginal opening, okay, which would be, you know, in this area right in here, the vaginal opening, basically in immature female and young females, is covered by a membrane which is called the hymen, which is partially covers the vaginal orifice of the opening. It's often broken or torn or stretched or ripped by injury, or sometimes first intercourse may do this. So that would be what may occur as well. On both sides of the vagina on the inside, and the vagina we know is basically a tube, okay, mucocutaneous tube, and what happens on both sides are what we call the Bartholin glands, okay, very close to the opening of the vagina, the Bartholin glands. And these Bartholin glands, one on each side, okay, basically what they do is they secrete mucus to be able to lubricate the vaginal walls, to keep them nice and moist and healthy. Okay, one other part that we should talk about as well in this region is the clitoris, or the clitoris, you know, which is going to be up in this area up in here, and basically that is an erectile type tissue that's anterior to the vaginal orifice. Also, it's superior to the urethra. If I look where the urethra is, okay, the urethra is going to be down in this area right in here, where the clitoral reaches up in there. Some cultures may actually do what they call female circumcision, where they actually go and surgically or ritually remove that area to decrease sexual sensation and so forth. And you know, and a lot of, you know, in some cultures will actually do that. Okay. The other area that we should talk about on this particular slide is the area it's called the perineum. Okay, and the perineum is the area that would be back in this area between the area of the external genitalia and the anus, and that would be called the perineum. It's sort of an interesting area because there's not much there. If you actually would palpate down in that area, you might feel like a very small ridge of skin that goes back from that area back towards the anus, and that's where some of the muscles, it's sort of a line where a number of the muscles that support the pelvic organs sit, okay, which is called the pelvic diaphragm, a group of muscles that actually hold things up. And where this becomes significant is because it goes right back toward the anus, and around the anus is, as you know, you may have heard when you looked at the gastrointestinal video PowerPoints, is there's a sphincter, a ring of muscles around the area of the anus that will allow you to be able to maintain fecal material until you're ready to deposit it. Okay, and what happens is sometimes during childbirth, as the head comes down the birth canal, things get tremendously stretched out, just hugely stretched out. And when that happens, sometimes there's actually ripping of the skin because of the stretching. It gets stretched so tight, things start to rip. And if it rips down that perineum, right down that little ridge area, it rips down into the area of the anal sphincter on the outside, which then becomes a little bit of a surgical nightmare to be able to get that back together. That's why sometimes females, if it looks like they're impending a rip, rather than have it spontaneously rip, the obstetrician might do what's called an episiotomy. Take a little pair of scissors and make a little angle, a little cut. And they usually angle it off a little bit to the side like that. And as a result, it's away from that rip back towards the area of the anal sphincter to protect that. And then all they do is suture it up after the baby's born, and after a few days it sort of heals over and stuff like that. So anyway, those are the external genitalia that we'd see in the female reproductive system. Let's talk about some of the internal genital organs that we have, including the vagina, the uterus, the uterine tubes or fallopian tubes, and the ovaries. If we look at this image right here, okay, let me just try to get you a couple ideas of where we're at here. If I look at this area right here, this is the bladder. This is the bladder sitting right in here. This area is the bladder sitting right in there. And what happens is what we see is posterior to the bladder is the area of the vagina, which is going to be this area right here. Okay, then posterior to the vagina is the area of the rectum, which sits right in here. So basically we have rectum, vagina, and then bladder. Okay, and the uterus sits over the top of the bladder, sits like here. So this area right here would be the area of the uterus. Okay, sits right over the top. Okay, of the bladder, and the angle between the uterus and the vagina is not quite a 90-degree angle, but there is an angle. Also, we find that what happens is the uterus, besides being in this direction, okay, it's also twisted a little bit. In other words, if we look at it, there's almost a mild twist going in this direction, which is the normal position. Okay, and what that means is the opening of the uterus, which sits down in this area, okay, I keep on popping that thing up, the opening of the uterus, which sits down in this area called the cervix, sits more on the roof of the area of the vagina, and we'll talk a little bit more about that as time goes on. Let's first talk about the vagina. Again, that vagina is a mucomembranous, mucocutaneous tube, has a smooth muscle lining on the inside, very stretchable. Okay, it has to be able to allow childbirth to occur, and it extends all the way from the cervix, okay, to the external orifice. Now, what do I mean by the cervix? First of all, that cervix is this area right in here. This is the cervix. Okay, so this area up in here is the uterus. This is the uterus, and part of the uterus actually protrudes down into the vagina. Okay, when they do a Pap smear on females, what they actually do is they take samples of the cells from around the opening of that cervix. Now, in that cervix, there's an area. It's called the os. Okay, here it says external os, but it's also called the cervical os because it's an opening. There has to be an opening of the area of the cervix, okay, to allow, if spermatozoa are deposited inside the area of the vagina, they have to be able to work their way up through that area, that canal, and out to the fallopian tubes, because fertilization occurs out here in the fallopian tubes. Okay, so basically that's what we see with that. Okay, and again, so we have the cervix at the deep end of the vagina, and then we have the opening or the vestibule that would be out in this area near the opening, and then a vaginal orifice would be in this area right here. Okay, Bartholin glands would be on both sides of the area of the vagina, again to provide lubrication to what you might see. On this view, again, this is over here looking on the right hand image. You see the bladder, and the bladder sits in one place, and just behind that would be the area. Right behind that is the area of the vagina, and then this area up in here again is the area of the cervix, and right through the middle of that would be that cervical os would be right here, and that this is called the endocervical canal. Endo means within, cervical means cervix, okay, and that would be the endocervical canal. Okay, function of the vagina, there's a number of functions. First of all, we know it has to be the inferior portion of the birth canal. In other words, the baby's head's going to be coming out the vagina eventually. We also know that what happens is it's an excretory duct for menstrual fluid. Okay, and I'll explain that at the very end of the female reproductive system PowerPoint. Okay, I'll explain a little bit more about what happens. We also know that vagina is the area that will receive the penis for ejaculation during intercourse. So therefore, what will happen is the spermatozoa will be deposited in the area of the vagina, and then the spermatozoa have to find their way up through that cervical os, up to the endocervical canal, through the uterine cavity out the fallopian tube to try to find an ovum that's been spinning and circling its way down the fallopian tube. Okay, so that's what happens. So again, it has to communicate superiorly with that endocervical canal. Okay. So, and again, I should probably remind people, I should have mentioned it before, again, this is some sensitive material, so I'd be a little cautious in regards to having younger family members and stuff like that around when you're watching this, okay? Just use your own discretion as regard to what you think is in good taste, okay? Again, normally the vagina just in a resting position is usually closed. It's sort of like collapsed anteriorly and posteriorly, except at the cervix. Okay, at the area of the cervix, there's an open area on both sides. Okay, and that's called the fornix. F-O-R-N-I-X. If you see the word fornix, that's what that is. That's the opening on both sides of the cervix. Let me get rid of this. So you'll see how there's a little bit of gap. It's sort of open right where the cervix is at the deep end of the vagina. Okay, the vagina actually has a tension very much similar to like if you're pressing on the tip of your nose. Okay, and that's what it's sort of. It's firmer than the vaginal tissue, but it's like it's a little. There's a little bit of a density to it, like the tip of the nose. Okay, and again, that fornix, that deepest portion. And if I was to try to be really cautious, back in here, little corner right there, and a little corner right there. So we actually have an anterior and a posterior fornix right in this area. It keeps on popping up. Right there and right there. That's where the fornix would be. Okay. Again, the anatomical relationship of the vagina is it's posterior to the bladder, so the bladder is here, and anterior to the rectum. Okay. One other thing I should point out to you in this particular image, which I think is quite important, is this area right here. This area right here. I'm drawing it in right there. Okay. And that little area is called the cul-de-sac. The cul-de-sac. It's also called the recto-uterine pouch, because it's a little pouch that sits in its peritoneal space. It's inside the peritoneum, inside the abdominal cavity. And the reason why it's important is that up in the top of the uterus, up in this area, would be where the opening of the fallopian tube is. If there's pus that develops in the uterus, it may actually come out the fallopian tube and drips down into that little cul-de-sac. Okay, so again, the cul-de-sac, the recto-uterine pouch, or sometimes called the pouch of Douglas. They're all about the same, all the same names. Okay, so basically that's what that little area is down there. Okay, and that's what that little pouches. And what they could actually do, if they think that there might be an infection that's coming from the inside of the uterus that's dripping inside the abdominal cavity, which causes a peritonitis, which is really a significant risk, what they could actually do is they could actually grab the cervix here and move that cervix forward and take a needle and stick a needle through the vagina into that pouch and suck out the fluid to determine what type of pus it is, or if it's blood or something like that. They can actually determine what's falling down in that little gap, that little pouch down in there. Okay, again, the important correlates that we have in regards to this is the vaginal skin, the vaginal tissue, the mucous membrane is very stretchable. Okay, and also during pregnancy, there are a number of hormones that are produced, and some of those hormones actually increase the level of stretch of things. That's why, you know, low back pain, arch pain, things like that has to do with both weight, because of the weight of the fetus and the uterus. What happens is, in preparation for the birth, various hormones like relaxin is a hormone. And what it does is it relaxes connective tissue, so it allows things to stretch a little bit more. So when the baby is being born, what happens is the vagina will stretch more, and it allows the cervix to stretch. When they talk about dilated, okay, and that's what happens. I'll talk about dilation and effacement in just a minute when we get to the cervix, when we get to the uterus. Okay, so as a result, what happens is we have to have stretching of the vagina to have the head come down that birth canal. Head's the biggest part, it's the hardest thing to come out. It looks just like the picture up in there. And basically what happens during birth, if you've seen a birth, you'll know what it's like. If you haven't seen a birth, and if you get a chance down the road, it's actually something that's really phenomenal. But what happens is that when the baby's head does emerge, it's outside, and at that point it's still stuck, because you still have the shoulders in a position. At that time, usually what happens is the doc, the nurse, the midwife, whatever the case may be, will suck out the nose and the mouth, get all the mucus and all the fluid that's out of the mouth and the nose. Okay, they usually check check around the neck, see if the cord's there, because you don't want to keep on tugging on the cord. It's not a real big deal. If the cord's around the neck, all they do is they take a clamp, they clamp it, cut it in between, and that's it. Okay, it's already cut. Okay. On the other hand, then what they do is once they get all that squared away, all they do is they take the head and lift the head up a little bit, like the bottom picture shows. They lift the head up a little bit, and that brings the bottom shoulder out. And then once that bottom shoulder's out, be ready to catch, because that thing comes squirting out like a torpedo. Okay, it's there's nothing else. Everything else is smaller, so it's pushed out quite rapidly after that point. Okay, I remember I delivered a couple babies when I was a PA, actually, as in training, and the first one I delivered, it was so fast. It was like, oh my gosh, I hope I don't drop this thing, because it just shot. Okay, I'm glad we didn't even get a chance to break the table down so I could, at least if it would fall, it'd fall on a part of the table. Usually the table is dropped at that point. That foot of the table is down, so you can't to catch it. Let's talk a little about the uterus now. The uterus is sort of like a pear-shaped organ. Okay, it's a very muscular organ. It has very muscular walls. So the muscle walls are in here. That's called the myometrium. M-E-T-R-I means uterus. Myometrium, myo means muscle, as we all know. So myometrium is the uterine muscle. Again, it's a pear-shaped organ. You can see it here. And again, if I'm drawing where the uterus is, this is the uterus right in here. Okay, it's a pear-shaped organ. It sits over the top of the bladder, like I mentioned. If the bladder's down here, that uterus sits right over the top of it with this top portion right here. This top portion right here is called the fundus. It's called the fundus. And that fundus, actually, when they do a bimanual exam or an internal exam, what they could do is actually push on the cervix. They put their fingers right here in the cervix and push the cervix forward, and that pushes the fundus against the abdominal wall. And you can actually feel the top of the uterus just over the top of the pubis. Okay, it comes right over the top of the pubis and stuff like that. The cervix is back in this area we talked about. And let me get rid of these pictures right here, and let me go ahead and get this. Let me do this. This area right here is the cervical region. Okay, and again, that protrudes into the area of the vagina. Usually what happens, like we showed before, that the uterus is what's called anteverted. Okay, if the vagina comes this way, the uterus is sort of like this because the bladder sits right here. Okay, we also know is the uterus is also what's called anteflexed. So instead of being straight, it actually comes and flexes around the top of the uterus this way. So it's both anteverted as well as anteflexed. So it's tipped forward as well as bent forward. Okay, and as a result, it sits right on top of the bladder, and that's what we call that's the uterus. Okay, this is again looking at it. You can see how that is. Let me get rid of those other drawings here and stuff like that. So we actually see the vagina would be here, and here's the uterus, sort of like tipping over the top of the bladder, which is sitting down in there. Okay, and that's that anteflexed, anteverted type of a position that we get with that. Okay, when I look at the uterine parts, okay, the upper 2/3 is what we see up in this area. Let me just do this. This would be the upper 2/3 of the uterus in here. Okay, and at the first portion we know is this area right here. This area right here and this area right there is called the cornua. Okay, it's called the cornua. Okay, and basically, or the uterine horns. Okay, and this is the area where the fallopian tubes, which are these things out here, where they actually enter into the uterus at the upper portion of the uterus, very close to the fundus. Okay, and that's called the cornua, or the uterine horns. Okay, the next portion of the uterus I want to show you will be the area of the fundus. Like I mentioned, this area right up in here is the fundus. It's a rounded area. It's on the interior-most portion of the uterus. Okay, it's right where the uterine tubes are going to come, right above where the uterine tubes or the fallopian tubes are going to be coming in to the area of the uterine cavity, which is inside there. The isthmus. Okay, the isthmus is this area down in here where the uterus starts to get narrowed. Okay, it's just a little bit above the cervix, and this down, because this down here would be the cervix. Okay, now the other thing that we have to look here is the uterine cavity. Here's the uterine cavity. Okay, and it's open to the outside. It's open through the area of that endocervical canal, and it's open through the fallopian tubes, which then the fallopian tubes come down this way. And now here's a key. What happens at the end of the fallopian tubes, the end of the fallopian tubes are open, and we'll talk about this in a little bit. There's little fingers that hang down there, and they're called fimbria. And what actually happens is this area right down here is open to the inside of the abdominal cavity. So what this means is the female peritoneal cavity is open to the external environment. Okay, the male abdominal cavity, you can't get in. Female, you can. And basically, if something like if there's certain bacteria infections that are in the vaginal region, they could go up through that cervical os, that opening, through that endocervical canal, through the uterine cavity, okay, out the fallopian tubes and drip out through the area of the end of the fallopian tube and fall in that little cul-de-sac like we talked about before, which then means that they get infection inside the abdominal cavity that actually came from the outside. Okay, so that's one of the differences, another significant difference between male and female reproductive system. Okay, so we see the uterine cavity. We also see the endometrium. Now, in this situation here, I'm going to have to use a smaller little marker here. The endometrium is just this lining that's on the inside. Okay, and usually it's relatively thin, but again, each month, under the influence of that hormone called estrogen, that endometrium gets thicker, so that if there is a fertilization which occurs out here in the fallopian tube, it does come down the area of the fallopian tube, has a nice place to land and sits in there. Usually what happens is most implantations, of a fertilized ovum occur somewhere up in this area, up in that area, or up in this area, depending upon which fallopian tube they came out, very close to the top. Okay, and that's where that usually occurs. So, and that right there is the fundus. I just showed the cornua in the one before. There's the fundus. There's the isthmus that's circled like I showed before. There's the uterine cavity. Okay, so we're good. Okay, the cervix. Cervix deserves a little bit extra attention at this point. And the cervix, as we talked about, was this area of the uterus down in here. Okay, that's the area of the cervix. Okay, it's sort of the cylindrical area. It's narrower inferior portion, and it does protrude the vagina because it becomes the opening from the vagina into the area of the uterine cavity. Okay, and this area, like I mentioned before, the area that's right in here, this cavity right here, that tube is called the endocervical canal. Oh, let me do that with this little thing here. Why do I do that? That's pretty, purple and green. Endocervical canal, okay? And that's the opening into the uterus from the area of the vagina, okay? And the opening right here is called the os, the external os, or the cervical os, which is, the word os means mouth or opening, okay? And that's the os, okay? When they do a Pap smear, well, I'll get to that. Come here. When they do a Pap smear, okay, this is what they see when they insert a speculum. What happens is if I look at the uterus is like here and the vagina is like here, so the cervix is sort of sitting on the top portion. But when they put the speculum in, that the cervix actually comes down a little bit. Okay, pulls it down a little bit, and so this area right in here would be the area of that cervical os, where that slit is. In a female who's never had a child, that cervical os is very round. In females who have had a child, the cervical os is more like a slit shape like we see right there. It's wider, okay, because it's been stretched out and stuff like that. When they do a Pap smear, a Pap smear is to look for cervical cancer, okay, and that's a whole other topic we could spend an hour just talking about cervical cancer on. But when they do a Pap smear, what they actually do in the Pap smear is they actually take a scraping, okay, and you can see what they're doing down here. There's a little spatula. Okay, this little thing right here is a spatula. It looks like this, it comes like that. They stick this part right here in the area of the cervical os, and they take this part and they twirl it around. They twirl it around this. That becomes a pivot, but they twist this part. This part in here then gains some cells as it scrapes the cells of the cervix around the outside. They just sort of twist it and twirl it, and they get the cervical cells from around the outside of the cervical os, going all the way around. They take those and they put them on a plate and they send them in. As you see right here, they're putting them on a plate. They send them in. They put them in a fixative and send them off to be looked at by the pathologist. You can see up there how they put the speculum in to be able to see that. You can actually see the spatula coming down in here. Okay. They also take an applicator or a brush, and they put a brush right up in that area of the cervical canal, endocervical canal, and that way they get in a little bit and they twirl that, and they're looking for the cancer that might have spread down the canal a little bit, which is different. So they want to get two separate specimens to get an idea where, if there is some change in the cervical cells that show cancer where they might be. The thing, very briefly, in regards to cervical cancer, in most cases, I can't say all cases, but in most cases, cervical cancer is a relatively slow-growing cancer. It takes a long time to go from precancerous stages to cancerous stages. Okay, so basically, if females have regular Pap smears like every year, every other year, they're going to catch something before it actually becomes cancer. So at the time when they start having not even before intercourse, usually even younger after puberty, they could start doing Pap smears, and what will happen is they're just looking for any kind of changes. So if there are changes, they can address it before it actually becomes cancer. A number of years ago, they came out with that HPV vaccine, human papillomavirus. Okay, and basically what they found was that almost all females, in fact all females with cervical cancers, were positive for having this HPV virus. Okay, so they created a vaccine which now they also give to younger males, simply because what happens if the younger males have HPV, they could actually transmit it to the females. So they give it to younger males. Also, there's other types of cancers that are associated with HPV, okay, besides cervical cancer. And there's a lot of controversy about it because cervical cancer is a slow growing, but actually there's a lot of things that can actually be addressed by HPV vaccine. Okay, when we look at the uterine wall, it's 3 layers. There's 3 specific layers of the uterine wall. The outside out in here is called the perimetrium. Peri means around, and basically what it is, it's basically the peritoneum. That peritoneum covers over the dorsal, the top portion of the uterus. The bottom portion is like right against it. The peritoneum tucks in a little bit between the bladder and the uterus, but that outer membrane we find on the outside of the uterus, the perineum, is actually peritoneum that covers the outside. The most important part is called the myometrium. The myometrium is all this material in here. Let me just do a different color so that is all this material in here. That's all the myometrium, okay? And basically that provides most of the bulk of the uterus. That's the part that when a female's in labor, they hate. They're starting to scream at. Darn uterus, because what happens is that's the area with all that contraction that actually will force the fetus out to be born. Okay, so that's the myometrium that's there. It's the middle muscular layer, has a lot of blood vessels, a lot of nerves and stuff like that. Okay, however, the part that really is significantly important for a number of reasons is this inside lining. Okay, let me just do it with this, that's better. Inside lining. Okay, and that inside lining in here is that endometrium. Okay, and each month, that endometrium during the fertile years, not after menopause and stuff like that, but each month during the fertile years, as the estrogen levels go up, like I mentioned before, it increases the thickness of that endometrium. The endometrial wall gets thicker and thicker and thicker. Just provides a better landing spot for a fertilized ovum to be able to stick to. If there's no pregnancy, okay, if there's nothing, and I'll explain a little bit more what happens at the end, but if there's nothing, then what happens is that inside endometrium will actually pretty much die and sloughs off. It falls off the inside wall of the uterus. That combined with the blood from that, the inside wall of the uterus, the endometrium and the blood is expelled then as menses. Okay, and that's what we have with menstrual flow, is actually a sloughing and loss of the endometrium plus the blood that goes along with that. Okay, and that's what happens with that. A couple things about the uterus, okay, that we should probably mention that I think are sort of different is this happens particularly more with what I call multiparous females. What I mean by multiparous means that they've had many children. Okay, multi means many, parous means delivery. So if a female has lots of kids, what happens is the muscles that support everything up in here. Remember before I mentioned the word the pelvic diaphragm, okay, through the perineum and stuff like that. There are a number of muscles that support all these pelvic organs to keep them up. Okay, what happens is over a period of time, especially with multiple deliveries, that pelvic diaphragm becomes really weak, and as a result, there's nothing to hold the uterus up to where it's supposed to be, and the uterus starts to fall. Okay, and that's called a uterine prolapse. A uterine prolapse, when that uterus starts to fall. Okay, and what happens is this is where it would, it would be starting up in here. Okay, but now you can actually see where it's sticking down more into the vagina than it should be. Okay, finally we get to what's called a second degree prolapse, and now it's about halfway down the vagina. If you looked inside the vaginal opening, you'd actually see the cervix like it's starting to pop out. And a third degree is where now we'll actually see the cervix outside the body. I mean, the first time I ever saw a uterine prolapse, my eyes almost popped out of my head, because you look in there and there's this large structure that's protruding out through the area of the vagina, simply because they lose that muscular support in the pelvic diaphragm. Okay, and that's called a uterine prolapse. What they have to do is they either do a hysterectomy on those, because again, usually occurs after multiple births and weakness of that pelvic diaphragm. But sometimes the bladder will also fall. And if we look over here, you can actually see how it sometimes will drag the bladder. Here's the bladder coming down. They actually will, I mean, you can get rid of the uterus, that's fine, but you can't get rid of the bladder. So what they do is they actually have to take and they bring the bladder up. Once they get the uterus out, they bring the bladder up and actually sew it to the front of the pelvis. The pubic bone up there, and it's a suspension, a bladder suspension, so it doesn't fall anymore. Okay, that's just another thing. Hysterectomy is just a removal of the uterus. Okay, sometimes they could do it vaginally, they could remove it through the vagina, sometimes they have to go through the abdominal wall and remove it. Depends upon what the problem is. A question that came up yesterday in another class somewhere else was, how about the ovaries? Well, if they could leave the ovaries and the fallopian tubes, they will. And the reason why they will do that is because the ovaries still continue to secrete a hormone, estrogen. If you take the ovaries out, then all of a sudden they go into like a premature menopause. So once the ovaries are removed, there's nothing to make the estrogen anymore, and as a result, estrogen supports a number of things like bone health and a number of other factors. So if you remove the ovaries as well, then what happens is then you lose that hormonal support. So a lot of times a hysterectomy will suffice, but not the ovaries and the fallopian tubes if they can avoid it. Okay. The uterine tubes. The uterine tubes are called the fallopian tubes, and again, they start at that cornua or the uterine horns at the superior portion of the uterine cavity, okay, and open out, okay, and it's a tube that'll come out that widens as it gets towards the end, okay, and it gets near the ovaries. Now, what happens is the ovaries and the end of the fallopian tubes are actually held in a ligament, and this ligament sort of holds them and suspends them from the side. And what happens is the fallopian tubes will extend out to a distance where they're very almost to the lateral side of the pelvic walls. Okay, we're not talking about a big space, but almost the lateral side of the pelvic walls. And the uterine tube sort of like arches over the top of the ovaries, and I'll show you what that is. There's a little bit of a variance in position and stuff like that, but that's what we see. And again, it gets wider as we get closer to the end. This is going back to the image that we saw before, okay? And again, if I look at it, this is the fallopian tube coming out here, and see how it gets wider, okay? This area out here is sometimes called the ampulla because it's much wider. And at the end, we have these little fingers, or the fimbria, and the ovary would be sitting right here. There's, again, ligamentous structures that hold everything together, okay? And that's where the fallopian tubes are. They're on the outside. So that's what we see. We see that, again, on both sides, the fallopian tubes. And this is just another segment looking at the difference of the fallopian tubes. And this is, again, that ligament, okay, that actually holds everything together, okay? It's called the broad ligament. There's a broad ligament, a round ligament that hold everything together, the fallopian tubes and the ovaries. But actually in this situation here, what we see is here's the fallopian tube coming over this way, and the fimbria would be out here, and the ovary sits right in that area right there, the ovary, and it would be very close to this open area called the fimbria. So don't worry about these infundibulum, ampulla, isthmus, and uterine part. That's really not, you don't have to worry about that, okay? Again, we talked about this before, and this is another important clinical distinction. Because the female peritoneal cavity is open to the outside, through the vagina, through the cervical os, through the endocervical canal, through the uterine cavity, out the fallopian tubes, and into that little pouch, infections then sometimes are able to spread from the outside, from vaginal areas, internally. One of the common ones that does that is gonococcus. Gonorrhea will actually cause a lot of pus that will form inside the uterus, and that pus eventually starts to come up out through the fallopian tubes and leaks into that area of that cul-de-sac like we talked about before, which is very different from males. Males get a urethritis, a burning discharge from the urethra in males with a yellowish pus-like discharge, where females will frequently get a discharge, a pus-like discharge from the, and they actually see it coming from the cervical os. But if the infection is large, the pus continues to build up and comes out the fallopian tube. Okay, so that's a problem, and that is called pelvic inflammatory disease. Okay, pelvic inflammatory disease, or you might have heard it as PID, pelvic inflammatory disease, and basically IV antibiotics and stuff like that. And one of the problems with pelvic inflammatory disease is if it's inflamed and infected, even when they get rid of the infection, it's not unusual for the fallopian tubes to be narrowed. There's scarring of the fallopian tubes, which means that the more often somebody has a pelvic inflammatory disease, the less likely they will be to have a fertilization occurring in that particular fallopian tube, because it gets just too narrow. Okay, so that's one of the things that they find. Tubal patency, and that's where patency means opening. Okay, again, when females have multiple episodes of PID, they lose that tubal patency, and what happens is they just the tubes don't stay open, and they're narrowed. They could actually take a tube and put it up inside the uterine cavity and put dye and watch the dye come out through the area of the tubes, and that's called hysterosalpingography when they do that, which is something that maybe you might be involved with if you do some type of interventional radiology down the road. Okay, or they could look inside with a scope, a hysteroscopy, actually a hysteroscope where they can actually look inside. Hystero, Hystero, is a word root that means uterus. Okay, Tubal Ligation. This is a way that they could prevent, or actually pretty much prevent pregnancy. And what they do with the tubal ligation is there's a number of different ways they could do it. When they talk about getting the tubes tied, this is what we see here. They actually take and they go into the abdomen endoscopically, with a tube, go inside and they find the area of the fallopian tube, and what they do is they tie it off or clip it off on one side and the other side, and they cut it in the middle. So now there's this gap in between. So therefore what happens is the ovum could come one way and the spermatozoa could come one way, but they never the twain shall meet. They can't meet because it's been cut in the middle. Okay, so that's a little bit about what's that type of. Sometimes they cauterize it, so what they'll do is they'll open it, they'll cauterize it, and by burning it creates a scar. I'm not sure if that's always that reliable, or if they could actually band it. Okay, and they sort of loop it up into a band like this, and they band it across and stuff like that. So anyway, there's lots of different methods, and we're not here to talk about the different methods. But if I have the ovum, if the ovum have to come. If the ovum, I'll do that in red. If the ovum have to come from the ovary and then come up the fallopian tube, and the spermatozoa are coming up to the endocervical canal through the uterine cavity, come out. If there's a gap right here, nothing gets across there, and therefore there can never be a union of a spermatozoa and an ovum. Okay, ectopic pregnancy. We'll talk a little bit, briefly about pregnancy in a couple minutes at the end of this video. What happens is most fertilization occurs in the fallopian tube. Okay, and one of the things that sometimes happens. Okay, well, I'll just go ahead and mention it now. When fertilization occurs in the fallopian tubes, inside the fallopian tube are small little things called cilia. Remember cilia, like in the respiratory tree? These cilia will carry the ovum down the fallopian tube. Okay. But sometimes it doesn't happen that way. Sometimes the ovum, the fertilized ovum, I say ovum, I should now be saying zygote, because zygote is a combination, we talked about it in the first lecture. Zygote is a combination where the spermatozoa fertilizes the ovum, and now we have one cell that becomes two cells, two becomes four, four becomes eight, and it keeps on multiplying. And what happens is that as that zygote starts to tumble and roll down the area of the fallopian tube, because aided by the cilia, sometimes it stops. What happens, it implants in the wall of the fallopian tube as compared to in the wall of the uterus, okay? And again, the most common place that we'd find that implantation would be down somewhere right about here on the lateral wall of the uterus. Up above, we don't want to go down here because that's a problem down here, but when we stay up in here, that's okay, okay? So the fallopian tube, the fallopian tube then becomes, in some situations, the place where that zygote sticks. And it sticks, it creates something called the chorion. The chorion becomes a little junction between the, which eventually transforms and stimulates the formation of the placenta and the amniotic sac. And this is called an ectopic pregnancy. Ectopic means outside the normal location. It's not occurring where it's supposed to be. It's pregnancy, yes, and the pregnancy test will be positive. The chorion, which attaches it to the wall, secretes a hormone called human chorionic gonadotropin, and that human chorionic gonadotropin rises in the blood and then spills over into the urine. So that's where where they get the home pregnancy test, where they actually test the urine. They can see the HCG in the urine. Okay, but if there's a problem with the fallopian tube as well, such as, let's say, there's a narrowing, a stricture because of pelvic inflammatory disease or something else, or prior ectopic pregnancy, okay, what happens is the pregnancy stops there, and that zygote embeds itself in the wall of the uterine tubes. Okay, it happens about 1 in about 250 pregnancies, which is actually a pretty high percentage when you think about it. Okay, one thing to remember about this is they're all non-viable. None of them will survive, and usually what they will do is they will spontaneously abort during the first 8 weeks of pregnancy, sometimes a little bit later. Okay, and it's usually all of a sudden and may be associated with a significant amount of rupture and hemorrhage. Okay, and as a result, that could be a significant problem. Okay, in fact, you know, if it's not picked up with the hemorrhage and the amount of bleeding that's inside the abdominal cavity, may cause a significant enough blood loss to produce shock and possibly death in some situations. I have a very good friend whose wife was pregnant. We were all excited for him and stuff like that. This is a number of years ago, and basically they were gone for a while, and his wife used to stay with us a few days a week because she worked here in Cleveland. They were living in Buffalo, and she was a veterinarian, so she'd come and stay with us in Cleveland, and they went to San Diego for a meeting. And turns out that when they were in San Diego, she got ill. She got dizzy and lightheaded. Turns out that she had a ruptured ectopic pregnancy, and as a result, obviously lost the baby, which was a sad thing for them and us, because we thought that they'd be great parents, which they are, because now they have 2 boys and 2 girls. Okay, and we just saw them probably a few months ago when they passed through Cleveland. Okay, so anyway, that's about ectopic pregnancies. They occur. The ovaries. The ovaries are basically almond shaped. They're not really very large. They're close to the lateral pelvic wall because, again, the fallopian tubes are coming to the pelvic wall. Now, I'm not talking about the abdominal wall, but the pelvis. You got to remember that pelvic cavity is much smaller than the abdominal cavity. Okay, and again, they're right next to, very close to where those little finger-like fimbria are at the end of the uterine tubes. And again, that's the site of where the ovum are and the site of estrogen production inside those ovaries. Okay, so when we look at that ovary, there it is, and there's where the ovary would be sitting in right here. And basically, this just shows a representation of the ovum being developed inside there. And again, it's held together by all this membrane, this ligament that holds everything together. And once the ovum is expelled, okay, from the ovary, it gets sucked up into the fallopian tube and starts to transmit itself or tumble its way down the tube by the cilia that are inside there. Okay, there's a condition called situs inversus, and situs inversus, people, it's not, I can't say it's common, but it's not like a total rarity. I have a cousin whose wife is a situs inversus. What happens is during development, everything's backwards. The heart, instead of being tipped to the left, is tipped to the right, and everything's backwards. And they have a few other problems. One of the problems is they frequently have a lot of bronchitis and respiratory problems. Why? Because for some reason the cilia in these people do not work. Okay, so I know she was always a sniffler, and she'd always have all these chest infections and very bubbly, and not a personality, but a bubbly respiratory tract. And also, they were never able to have children, so they adopted two kids from Korea. Anyway, that's about the cilia and stuff like that, and with the ovaries. Okay, um, again, this is just looking inside. This is a laparoscopy, where laparoscopy they're able to go in with a tube and they can actually see. If you look at this image, it's sort of small here. But this right here is the fundus of the uterus. There's the fallopian tubes coming off the side. Okay, they just go with the scope. Now, I want to just go over a couple things for you on this to talk a little about the physiology of what really happens, because we've talked about the anatomy and we know what all the anatomical structures are, but I want to talk a little about the physiology of what really happens every month in a female that's during those fertile years. The first thing that happens during that, I should show, is this area right here. Is this FSH? The FSH again is something. So where this would be the area. This is the menses right here. There's a shedding of the endometrial wall. At that time, the brain knows that there's no pregnancy, but says, you know what? Let's get ready for the possible next month, and it may happen then. So at the time when the inside lining, the endometrium is being shed right down here, okay, the pituitary gland secretes this hormone called FSH, follicle stimulating hormone. And what that does is starts this little thing on the bottom shows the development of the endometrial wall, how it gets thicker and thicker and thicker. Okay, you see down here the endometrial wall is getting thicker as the time. And what's doing that is the FSH is actually causing the ovum to start to develop. So let's go up to the top here. Inside there we have a follicle, and that follicle is starting to develop and get larger and larger and larger, and the ovum inside there is getting more and more mature. At the same time the FSH is increasing, we also see an increase in this other hormone right here called estrogen. Okay, now estrogen is really important because estrogen is what thickens the wall. Okay, FSH starts to prepare the ovum. Okay, and because of that, it stimulates the production of this estrogen that increases, and the estrogen is what's actually increasing the thickness of the wall, and it continues to get thick. So the estrogen continues on, it tapers off a little bit near towards the end, but it's still there, but it's making the wall thicker. Okay, in the middle of the cycle, okay, we have this big rise of this hormone here called LH. LH stands for luteinizing hormone. What luteinizing hormone does, that's called the LH surge. And that LH surge right in the middle of the cycle is what actually stimulates that ovulation. It stimulates that ovulation to occur, and that ovum is expelled through the wall of the ovary. Okay, so FSH develops the follicle. Estrogen increases the thickness of the wall. LH causes the ovulation to occur. Also, once ovulation occurs, as that ovum is spit out, the inside of that cavity where the ovum was fills up with this yellowish material called the corpus luteum. The corpus luteum feeds back to the brain, okay, and says hold off on the FSH for a while, simply because we have to wait and see if there's pregnancy. But what it also does is it causes secretion of this other hormone called progesterone. And progesterone makes all these gaps, makes it more glandular, makes the lining of the uterus better. Okay? So this all starts out with FSH stimulating the follicles. Okay? And let me just do it this way. Okay, let me get rid of all these. I'll do it sort of color-wise. Okay? So what happens is FSH stimulates the follicles. The follicles get bigger. Okay, that starts off, and that's from the pituitary. That's from the anterior lobe of the pituitary. What happens then is the estrogen starts to increase as a response. Okay, and what that does is that increases the thickness of the wall of the uterus, makes it thicker and thicker. And then what we have is we have the LH that comes from the pituitary, that LH surge coming down in here, and that causes ovulation from the LH. Okay, also allows those follicles to fill with that yellow material, that corpus luteum that feeds back to the brain and says hold off for a little bit, we're going to wait for a couple weeks just to see if we're pregnant. Also, it produces it stimulates the production of this thing called progesterone, which makes this much more glandular, which makes the uterine wall better. Now, here's what happens. If there's no pregnancy, let me put it if there's pregnancy. If there's pregnancy, what happens is that fertilized ovum somewhere down in this period, a couple days after ovulation, when fertilization would occur, that fertilized ovum sticks to the wall of the uterus. When it sticks to the wall of the uterus, it makes that chorion like I talked about before. That chorion feeds to the brain and says, hey, we're pregnant. Don't do anything else. We don't need more FSH. Why? Because we can't have a pregnancy on top of a pregnancy. Okay, you can't deliver 1 month and say, oh, the other one will be born next month. It doesn't happen that way. Okay, so it feeds back to the pituitary and says no more FSH simply because we're pregnant. Okay, and then the pregnancy will continue from there. On the other hand, if there is no pregnancy, okay, and there's no corpus luteum, if there is no chorion, what happens is that corpus luteum starts to degenerate. We're talking about in here. And what does that corpus luteum do? It helps to make the progesterone. So then what happens if there's no pregnancy, the progesterone levels will start to fall. You can see it here at the end, starts to fall. As it falls, the estrogen says, you know what, I'm going to fall too. The estrogen starts to go down. At this point out here, it stimulates the release of certain what are called prostaglandins. And the prostaglandins are good for some things. They actually make the mucus that protects the stomach from the stomach acid, like we talked about in the GI system. It also opens up the bronchioles, helps in breathing a lot. But what happens is it also causes pain and vascular spasm. So it causes the vessels to actually squeeze down. So the vessels that supply the endometrium squeeze down, and all of a sudden the endometrial lining gets shifted off or sloughed off, and that starts menses, which starts this part in here. Okay, so all of a sudden now all the inside wall of the uterus is sloughed off and lost, only to start again back in here. Okay, and that's what happens on a month-to-month basis. Okay, so if there's no pregnancy, the estrogen and progesterone levels go down, and the endometrial wall is sloughed, and at that point the brain says, okay, there's no HCG feeding back to say they're pregnant, so therefore let's go ahead and try another month. And you try the next month with the FSH, and the FSH then stimulates the follicles to develop with the ovum and stuff like that, just like we talked about there. So it's actually a reproducible cycle that goes like every 21, 28, 30 days, something like that, to be able to go through this process again and again and again and again until the ovaries say, hey, you know what, there ain't no more ovum here. We can't do this again because we're basically running dry. The well's dry at this point, so as a result, then there's no more. Then things start to slow down. The estrogen secretion goes down. Why? Because there's no need to increase the thickness of the wall of the uterus, and therefore menses starts to taper off. All of a sudden, it's gone. Okay, and that's that menopausal period, which is anywhere from 6 to 9 months usually. Okay, and this is again with pregnancy. And in pregnancy, what we have is the zygote implants on the uterine wall. If the zygote implants at the bottom, right by the endocervical canal, they call it, and the placenta develops. It actually blocks the way for the fetus to eventually come down at the end of pregnancy, and that's called a placenta previa. Okay, and it's a little bit of a problem. It's not. They'll know that's there, and they could work around it. Again, gestation is usually about 40 weeks, somewhere in that range. My older son was 41. My younger son was about 35. So it does change a little bit in regards to time. And again, we talked about the HCG, the human chorionic gonadotropin, which feeds back to the pituitary that stops the FSH release. Okay, and this is from ovulation to implantation, where we have the ovary, and you start. Here's a small ovarian follicle. It starts to grow, and it's extruded out. Okay, and you can see that ovum starting to go down and work its way down the area of the fallopian tube, meets a spermatozoa somewhere in here, and now you see a zygote. It's right there. That zygote tumbles on down the wall, finally comes down and implants up here near the area of the uterine horn. Okay, and what happens is this area right here, that's that corpus luteum that will secrete that progesterone to make the wall better, more glandular. Okay, so that's from ovulation to implantation, like we talked about before. So that's a little bit about that stuff. So anyway, this is sort of a quick, brief run through of the female reproductive system. I know we're not going to be, we'll be talking about the male reproductive system in the next video PowerPoint that you can watch. But that's pretty much it, where everything comes together. Again, there are a limited number of organs. They all work in concert, and the hormonal balance that we find in regards to how the hormones work on a monthly basis is pretty precise. Okay, if there's something off, then what happens is that may limit the ability to become pregnant, or if there's a problem with the cilia, or whatever the case may be, if the tubes are narrowed or something like that. So lots of different things. Years ago, in females, we kept on having spontaneous miscarriages or spontaneous abortions. I probably mentioned this in the first video, but if you forgot it, what they found was a lot of times in females, the estrogen was thickening the endometrial wall, but there wasn't enough progesterone to make it good and like sticky. So as a result, what they do is they gave some medication called DES, diethylstilbestrol, which actually helped females to go into full term and deliver their babies, and instead of going with spontaneous abortions. It turns out that their female offspring were much more likely to develop certain types of vaginal carcinomas, so which is not a good thing. But anyway, those are a little bit about the organs, a little bit about the reproductive physiology that we have in regards to the female reproductive tract, and hopefully it was informative for you. So now everybody will understand a little bit about what happens as time goes on. Okay. If you have any questions about this, obviously you could always give me an email, and I'll be more than happy to answer any questions that someone might have. So for now, be safe and be healthy.